Students, this is Dr. Manjinder Kaur, and we'll be discussing the various questions which had come on this year's INI-CET held on 9th of this month. Now, these questions, they are primarily based on the recall by the students which had taken this exam. So, these are at the best most closest to the questions which they have witnessed in the exam. There might be some variation based on the recall. In this exam, there were around 12 questions which we could say they had come from physiology, but they were mostly, integrated with medicine. So directly, they were not from the basics of physiology. Only a very few questions I would say that they were from physiology, but there is a deep integration with the medicine here in these questions. And you may come across many questions in the discussions of medicine also, where you would feel that this question may be considered in physiology. So primarily, it is very difficult to dissociate physiology and medicine because the basics of all the general medicine things or the concepts is going to come or be derived from the physiological basis. The questions which were mostly they covered the most of the areas, but I would say that they mostly the two questions were from ECG. Even we could see from homeostasis. So general physiology takes a very important part in the this entrance exams. And the were based on the physiological basis or on the concepts which are behind the various clinical conditions. The overall difficulty level I would rate between the easy and moderate. Now let's see the first question, which said that in myasthenia gravis, why does repetitive nerve stimulation shows a decremental response? So before we go into the question, let's first understand what is a decremental response. So whenever you stimulate a nerve, it stimulates or the signal is transmitted to the muscle and it stimulates the muscle and the action potential is generated in the muscle. So, on the repetitive nerve stimulation, which is done by the nerve conduction studies, also called as the electrodiagnostics, these successive potentials, action potentials, they are in the muscle, they have the same amplitude as of the first stimulation. So this is a normal repetitive nerve stimulation. But in case of myasthenia gravis, these successive action potentials, they show decrease in the amplitude, and this is called as the decremental response. So now here the question is they are asking that why the repetitive nerve stimulation shows a decremental response. To understand that, we would need to understand the physiology of the nerve conduction or the conduction of the impulse from the across the neuromuscular junction. So here in the neuromuscular junction, we have presynaptic terminal which is made by the nerve and postsynaptic membrane which is made by the sarcolemma of muscle. The nerve terminal has the synaptic vesicles, mitochondria. Now we have the voltage gated calcium channels here, which result in the influx of the calcium, which stimulates the docking of these vesicles into the release site, and they release the acetylcholine into the synaptic cleft. Now, this acetylcholine, it binds to the acetylcholine gated sodium channels which are present in these subneural clefts which are lying just below the dense pores. These are the voltage gated sodium channels. So here in myasthenia gravis, it is this acetylcholine gated sodium channels against which the antibodies they develop, and they decrease the number of these acetylcholine gated sodium channels. So every time the impulse is generated, only a few channels are available to bind with the acetylcholine which is released from the presynaptic terminal. Due to that, the repetitive nerve stimulation exhausts the amount of acetylcholine which is released, and hence there is a decrease in the response of the muscle, resulting in the decremental response, and clinically it appears as the fatigue on the repetitive movements. So hence, uh, we can see here in this diagram also that the acetylcholine is binding to the acetylcholine gated sodium channels, which results in the end plate potential. So now when there is decrease in this number of these channels, the motor end plate potential, its amplitude will decrease with the repetitive nerve stimulus. Hence, the answer here would be C, reduced number of functional acetylcholine receptors at the postsynaptic membrane. Let's see the other choices also, which says that decreased release of acetylcholine from presynaptic terminal. So you could see that there was no decrease in the release of acetylcholine from the presynaptic terminal because there is no problem with the presynaptic terminal. There is increased degradation. Now, in which condition there is increased degradation of acetylcholine? Normally, the half-life of acetylcholine is very less. So, what is the other clinically important thing which could be, integrated, which I would like to tell you here, that the acetylcholine esterase is very active. It degrades the acetylcholine in the normal physiological aspect also within 1 to 2 seconds only. Now this acetylcholine is broken and it is taken back by the presynaptic terminal to generate fresh acetylcholine. But in case of the organophosphorus poisoning, this acetylcholine esterase, it gets blocked. So because of the blockage of the acetylcholinesterase enzyme, there is increase in the levels of acetylcholine in the synaptic cleft. Now in that case, the acetylcholine receptors, these receptors, they will get more, or the more acetylcholine would be available, hence resulting in the overstimulation of these receptors, hence the symptoms of the OPC poisoning. Then the autoantibodies blocking presynaptic calcium channels. So here there is no problem with the blockage of the presynaptic calcium channels. The other clinical condition, which is called as the Lambert-Eaton syndrome, in that case the presynaptic calcium channels are damaged or blocked, which results in decreased acetylcholine secretion from the presynaptic terminal. So in that case, Lambert-Eaton syndrome shows an incremental response to the nerve conduction studies on repetitive nerve stimulation, which means that every stimulation is going to increase the amplitude of the um, conduction. So now here, this kind of response, when you get, it is called as the incremental response, and it is seen in the Lambert-Eaton syndrome. But in this case, our answer here is the answer C for myasthenia gravis, where there is reduced number of functional acetylcholine receptors at the postsynaptic membrane. The next question was based on the ECG, in which they have asked us about the peak P wave or the P pulmonale on ECG. They are commonly associated with which of the following condition? As you can see, that the name P pulmonale comes from the condition which is going to be always related to the pulmonary system. So, tall or peaked P waves is usually, it is associated with the conditions of the lung. For example, there is pulmonary hypertension, there is COPD, which increases the pressure in the right heart or the right ventricle. Because of this increased back pressure in the right heart, there is increase in the pressure in the right atrium also. So basically, all conditions in which there is increase in the pressure of the right ventricle and right atrium, it is going to result in P pulmonale or the tall P wave. So, but here in the choices, as you could see, you don't see any of the conditions which are associated with lung. So the only cardiac condition which can be related here is when there is increase in the right atrial pressure and resulting in the right atrial enlargement or the hypertrophy. So now in that case, here you would see that there are two ways to look at this question. Choice number A, B, and C, they are pertaining to the left heart, and only the D pertains to the right heart. Moreover, this condition of tricuspid stenosis is going to hamper the flow from the right atrium to the right ventricle, increases afterload on the right atrium, resulting in the right atrial enlargement and hence the tall P wave. Let's see. So let's see that what are the other ECG findings if there is the right atrial enlargement or the left atrial enlargement, or if there is a biatrial enlargement. So here a normal P wave looks like this in a lead 2. Now we are comparing the ECG, the P wave on ECG in lead 2 and lead V1. And so in lead 2 you can see a simple P wave, but in V1 you can have a biphasic P wave which is normal. So uh, in case of the right atrial enlargement, which we also called as P pulmonale, we will call it as the right atrial enlargement if the P wave becomes more than 2.5 mm in the inferior leads, that is in lead 2, lead 3 and AVF, and it is more than 1.5 mm in lead V1. So you can see that whenever there is a tall P wave, it pertains to the right atrial enlargement, and a broad P wave is indicative of the left atrial enlargement. So we have discussed what are the various causes of the right atrial enlargement. So you can see that most of the cases it is associated with chronic lung disease, which we also called as cor pulmonale. So, and also the primary pulmonary hypertension. The cardiac diseases which cause the P pulmonale are the one which result in right atrial enlargement. That would be the tricuspid stenosis or the various congenital heart disease like pulmonary stenosis or tetralogy of Fallot. Moving to the left atrial enlargement. So the left atrial enlargement is seen when there is a broadening of the P wave. So this means that there is a bifid P wave with more than 40 millisecond between the two peaks. And in V1 also you would see there is a biphasic P wave. Right. So now here the duration as well as the bifid P wave is seen here. The most common, or we can say the commonest cause of this left atrial enlargement is mitral stenosis. Hence, this wave, which looks like M, is also called as the P mitral, as it is associated with mitral stenosis. So this, if there is in isolation, only the left atrial enlargement is there. So the most common cause would be mitral stenosis. But if it is also associated with the left ventricular hypertrophy, so left atrial and left ventricular hypertrophy, when they occur together, that is seen in the systemic hypertension, aortic stenosis, mitral incompetence or mitral regurgitation, hypertrophic cardiomyopathy. So now we would see if you get the isolated P mitral, or we can say the bifid P wave, or the you have a broad P wave, that would be seen as mitral stenosis. So in case of a biatrial hypertrophy, when both the atria are hypertrophied, in that case you can have a bivalvular disease or the other common associated diseases like lung disease, plus the systemic hypertension is there. So or there is mitral stenosis. So if there are multiple causes, it is going to result in biatrial hypertrophy, and hence the changes where you would have the tall as well as the broad P waves. Hence, the answer for this question is tricuspid stenosis. In the next question, which of the following is awarded the Nobel Prize in Medicine for the year 2025? So, let's first see that who got this Nobel Prize in the year 2025 for medicine and physiology. So these three scientists are Mary, Fred, and Shimon. So now these three scientists, they are awarded the Nobel Prize in Physiology or Medicine 2025 for their fundamental discoveries relating to peripheral immune tolerance. The laureates identified the immune system security guards, that is the regulatory T cells, which prevent the immune cells from attacking our own body. So now this wonderful discovery, it has opened the gateway to find the new arenas and avenues for the treatment of the autoimmune diseases, the transplantation, and hence the new, we can say the gateways are opened to the medical fraternity. So the answer for this question is that the Nobel Prize was awarded in for peripheral immune tolerance by finding its role on the regulatory T cells. So now here you would see that it is important to look into the current or the recent advances in medicine, especially whenever you're preparing for your high stake exams, especially for the INI-CET. Please do not forget to have a look or a glimpse into the last 5 years of the latest discoveries, at least the Nobel Prize in the medicine and physiology. Apart from this, even a few recent advances which are happening around uh, your exam. So you keep a look out into the recent advances because you would agree with me when it was COVID, the COVID had taken up most of the questions in any papers. So in that case, keeping a lookout for the recent advances is always a good idea because I would also expect one question at least from such topics of interest. This is a very important question and a very interesting one. In this, so this is the pressure volume loop of the cardiac cycle. So here the question was asked that when the pressure increases from C dash to D dash and the volume remains constant, which of the following is true? So normally we read about this pressure volume curve in from C to D. We This happens in the normal physiological range. So C dash to D dash tells us that there is increase in the, we can say that the pressure, or we can say the left ventricle has to increase up to C dash now instead of C to open the aortic valve so that it pumps its blood into the ventricle, and here we can see that the ventricle is trying to contract against the increased resistance, increased afterload. Now this is particularly seen when there is increase in the peripheral resistance, and hence our answer would be increased peripheral resistance. The next question is, during normal inspiration, why does systemic blood pressure slightly decrease? So when you are inspiring, the intrathoracic pressure, it decreases, it becomes more negative. So this decreases the venous return to the thorax and decreases the venous return to the right atrium. So in beginning of the inspiration, because of the thoracic pump, there is increase in the systemic blood pressure. So there are two things. In the beginning, there is increase in the systemic pressure. But when the inspiration continues, in that case, the venous return decreases during the inspiration, and this decreases the blood moving into the left ventricle. So at the peak of inspiration, there is decrease in the blood reaching the left ventricle, and hence there is slight fall in the blood pressure due to decreased venous return. And hence here the answer would be C, that is decreased venous return. Secretion in GIT has the lowest sodium concentration. This was the very, very simple question. I would say, and one of the easiest ones. So we all know that the saliva is the hypotonic solution when it is formed. So I hope you would remember that the saliva is formed in the salivary glands. So once it is secreted in the primary secretion, it has sodium, potassium chloride, but when it is passing through the ducts, most of the sodium is reabsorbed, right? So, and the potassium is secreted into the saliva. Hence, the saliva becomes hypotonic in nature. So, the saliva is the one secretion in the GIT which is lowest in the sodium concentration when secreted at rest. That is why when you are drooling or when you are salivating, your saliva starts feeling salty because this sodium reabsorption is hampered in this case. The saliva was not a choice, then the second would be the colonic secretion, where the sodium content would be low because of the absorption of sodium here. But now the answer here is saliva. The patient's blood report shows MCV of 76 femtoliters. Which of the following conditions is most likely responsible for this finding? So here they have given us only the MCV. They have not talked anything about MCHC or MCH, right? So the other parameters we have not been given. Only one parameter is given, right? So here we know that in vitamin B12 deficiency there is increase in the MCV. The iron deficiency anemia, thalassemia, and sideroblastic anemia, all these three they have low MCV, but in addition, there are many other particular, we can say, findings in the peripheral smear, which will help us diagnose or differentiate between these three conditions. But on the basis of MCV, all the three, 2, 3, and 4, they are having low MCV. In iron deficiency anemia, the I mean, say the early onset during the initial stages, the MCV may not be decreased, but yes, gradually the MCV would decrease. The thalassemia would present with the target cells, and you would also see the MCV, but there is normochromia in them. And even the sideroblastic anemia would have particular features. So here the correct answer would be C, that is the 2, 3 and 4 all are correct. Only one is incorrect where there is increase in the MCV. A normal MCV or we can say an MCV less than 80 femtoliter is considered as this microcytic. So now this question is very interesting. Which hypothalamic nucleus is involved in leptin resistance? So now the most of the students would get confused between the ventromedian nucleus, which is also called as the satiety center, and it also has the receptors for the leptin. Even the lateral nucleus has the receptors for leptin. But uh, here, the ventromedian nucleus is also called as the satiety center. The lateral nucleus is also called as the feeding center. Here, one thing we have to see that in obese individuals, or if we talk about the leptin resistance, the circulating leptin levels are high. So here, the leptin receptors, they become resistant to the leptin. Now, these leptin receptors, they are present in the arcuate nucleus. So it's very interesting to see that the arcuate nucleus, it has two type of neurons. The first is the pro-opiomelanocortin neurons, and these neurons, they promote the satiety and energy expenditure when they are activated by leptin. Whereas the other type of neurons, which are the neuropeptide Y or agouti-related protein neurons, they stimulate appetite and they decrease the energy expenditure. And the leptin inhibits these neurons. So now when there is leptin resistance, in that case, the POMC neurons, they do not respond to leptin. And hence the person becomes obese, or the leptin related, or we can say leptin resistance related obesity occurs. Hence the correct answer here would be arcuate nucleus. So this is one of the very simple questions which you would see over from the general physiology. So they have asked you to simply identify what type of uh, transport mechanism is happening here. So here you can see that the 3 sodium, they are moving out, and 2 potassium, they are moving in, and the energy expenditure is happening. So you could see some ATPs here, the sodium, they are moving out, and the potassium, they are moving in. So this is the sodium potassium ATPase. So now the next question is, magnesium is primarily regulated by which of the following processes? The magnesium is primarily regulated by the urinary reabsorption. So there are 3 sites of magnesium reabsorption. The one is at PCT, second is at the ascending limb of loop of Henle, and the third is DCT. So around 10 to 25% of magnesium is reabsorbed back in the PCT, which is a passive paracellular reabsorption, and it is driven by the electrochemical and concentration gradients. Right? Uh, the most important site for the reabsorption of magnesium is the thick ascending limb of loop of Henle, which is responsible for reabsorption of around 50 to 70% of the magnesium. And this is driven by the luminal positive transepithelial voltage, which is created by the active reabsorption of sodium and potassium. So, these this reabsorption is also regulated by the reabsorption of calcium, and there is some influence of the hormones also occurring at this particular point, which we can say is because of the parathormone or estrogen that results in the reabsorption of magnesium at the thick ascending limb of loop of Henle. The DCT also accounts to around reabsorption of around 10% of the reabsorption depending on the need of the body. So we can say around 90% of the magnesium is reabsorbed back from the urine. Hence, your answer here would be A, that is urinary reabsorption. Which of the following represents most stable and long-term mechanism of homeostasis in human body? So here the choices are urine output, respiratory rate, oxygen saturation, and heart rate. The respiratory rate is a short-term regulation which is brought about by your carbon dioxide levels. So it is an example of short-term regulation. Even the oxygen saturation is the short-term regulation. The heart rate, which is maintained by your baroreceptor, it varies with every beat. The RR interval varies with every beat. Hence, the heart rate also is a type of short-term regulatory mechanism. So, out of these, the urinary output is the most stable long-term mechanism because it is required for the regulation of blood volume, blood pressure, electrolyte balance, and the kidneys through the production of urine controls the excretion of water, sodium, and other solutes, and it helps in maintenance of internal environment of the body. Hence, the most stable long-term mechanism of homeostasis in the body is urinary output. So, dear students, we have discussed all the questions which had come in physiology in this INI-CET, and I again say that they were based on recall. There might be some discrepancies which you may come across in the questions, that this was the question, and on the various other platforms. But to our best effort and our best knowledge, we have tried to access all those questions from our dear students who have appeared in this INI-CET. And I wish you all the luck for your exam. And I am quite hopeful that this video would be helpful for you to prepare for your INI-CET and the other entrance exam. Keep learning, keep growing, keep on doing well. With signing off with DigiNerve, this is Dr. Manjinder. All the best.